This lecture is on antidepressants. So antidepressants are an effective treatment for major depression. The majority of patients will fully recover when an adequate trial of any antidepressant is used. And an adequate trial means that they have taken it consistently for at least a couple of months and they've been on adequate doses to the full, titrating up the dose of the antidepressant to the max dose and making sure that they don't respond at higher doses as well. Antidepressant medications significantly reduce the length and severity of the symptoms, so if they're not treated, their depression can go on and on and on for a very long time. Also, the chance of relapse is very high, so you should continue the medication after the first episode of depression in order to prevent relapse for at least 6 months or longer. And any decision to taper it should be slow and monitored very carefully. There's 4 major classes of antidepressants. They're the tricyclics, the MAOI inhibitors, the SSRIs, and there's other atypical type of antidepressants that don't quite fit into any of these other categories. We'll first talk about the SSRIs. They are the safest, the best tolerated compared to the other categories of the antidepressants. They have the least amount of problematic side effects. So because of this, they're generally the first-line treatment for depression and many of the primary anxiety disorders like generalized anxiety disorder because they're a lot better tolerated, not necessarily because they're the most effective. Side effects are generally mild, but they can include GI disturbances like nausea or diarrhea or stomach upset. It's the most common. It usually occurs in the first week or so of starting the medication. And I generally just tell patients that it's a nuisance side effect that goes away after their body adjusts to the medication. Other mild side effects include headaches, sexual dysfunction, and a possibility that they get this rebound anxiety, and this also occurs in the first few days of treatment. They might feel a little bit anxious, and I normally just tell them to let their bodies adjust to the medication. It generally goes away, and it's usually not that disturbing. So what's the mechanism of action of the SSRIs? There's a lot of different theories. SSRIs, they inhibit the reuptake of serotonin, which causes more serotonin to be available in the synaptic cleft. This phenomenon occurs pretty much immediately, but clinical response, so the patient's symptoms don't really respond for 3 to 6 weeks. Therefore, this explanation can't fully account for why there's a delay in patient symptoms resolving. So there's probably more to the story, but the bottom line is nobody really knows for sure how exactly they're working. Here's a diagram that shows how the SSRIs work. You can see that the SSRI blocks the reabsorption of serotonin in the presynaptic cleft there, which makes it so there's more serotonin in the synapse that's available to be taken up by the postsynaptic. Some examples of SSRIs that you'll need to know, the most common one being fluoxetine, which is the oldest one. It's also known as Prozac. It has a very long half-life. So if patients forget to take their medication or if you stop their medication abruptly with Prozac, they won't have any withdrawal type of problem from it because it'll just gradually get out of their system. So you don't need to taper these patients off their medication if you do decide to stop it. Paroxetine or Paxil, on the other hand, has a very short half-life, and if you stop it abruptly, patients will go through a very uncomfortable withdrawal type of syndrome. Usually about flu-like symptoms, muscle aches. It's not pleasant. So make sure that you taper this if you want to stop this medication with patients. Paroxetine also causes a lot of weight gain, so keep this in mind as well. Sertraline or Zoloft. Most common side effect with this is generally GI upset. Usually during the first week, and it's mild. Normally it gets better after the first week. may cause some sleep changes. Fluvoxamine, which is also called Luvox, is FDA approved for OCD, obsessive compulsive disorder, and GI upset is also common with this one. Citalopram is also called Celexa. It has the fewest number of drug interactions. However, there's this new warning that warns about not going over a certain dose of the medication because of prolonged QT. So because of this, we're now cautious with citalopram, especially in anyone who has a history of arrhythmias or cardiac problems. We also will now get a baseline EKG with citalopram before we start it and before we increase the dose. Lexapro is just an enantiomer of citalopram. They're very, very similar, and their side effect profiles are similar as well. Serotonin syndrome. This used to be a lot more common a long time ago when SSRIs didn't exist yet and where the most common treatment was with MAOIs and tricyclic antidepressants. They're a lot more likely to cause serotonin syndrome. But we do see it occasionally with the SSRIs. You need to keep in mind that when you're switching someone from an SSRI to an MAOI, you need to have a washout period of at least 2 weeks after stopping the SSRI. This is because they have generally long half-lives and it takes a while for it to get completely out of the system before you start an MAOI. And with fluoxetine, which, as you remember from the previous slide, has the longest half-life, you need to wait at least 5 weeks before starting an MAOI. Serotonin syndrome, you need to recognize this in patients because it can be deadly. It is easily treatable with the supportive care for the most part, but if you don't recognize it, it can cause death. Generally, patients will present with a history of being on some sort of SSRI, and they might be on another medication that is contraindicated with their antidepressants, which ends up causing serotonin syndrome. You'll see the patient has lethargy, restlessness, confusion, diarrhea, flushing, sweating, tremors, myoclonic jerks, they're hyperreflexic, and then when it starts getting bad, it progresses to hyperthermia. They'll have a really, really high fever, 104, 105, 106, and it just keeps going up. Rhabdomyolysis, which ends up causing the renal failure, and seizures, and then lastly, coma and death. Here's a picture of a patient and what you may see in really severe serotonin syndrome. So you see the increased bowel sounds, diarrhea, agitation, diaphoresis. Their pupils are dilated, they're tachycardic, they have autonomic instability. The next thing we'll discuss are the norepinephrine dopamine reuptake inhibitors. This is basically bupropion. It's one of those special type of antidepressants that doesn't really fit into any of the other categories. Bupropion side effects include agitation, insomnia, weight loss, headaches. Pretty mild for the most part. Generally, patients tolerate this medication pretty well. The good thing about it is that it doesn't cause any sexual side effects. So in a patient with depression who's really concerned about sexual side effects or has been on an SSRI before and had sexual side effects, this is probably a good medication to start. Keep in mind it's contraindicated in patients with a seizure disorder or eating disorder patients because it does lower the seizure threshold. And always don't co-administer with MAOIs due to the risk of serotonin syndrome. And that's pretty standard with any of the antidepressants. SNRIs, serotonin norepinephrine reuptake inhibitors. This is venlafaxine, which is Effexor, and desvenlafaxine, Pristiq, and duloxetine, which is Cymbalta. Generally, you're going to see side effects similar to the SSRIs, pretty mild. A special one with venlafaxine is that it may increase the diastolic blood pressure from its baseline. Only about 10% of patients have this problem, and it's usually at the much higher doses of venlafaxine. It has a real short half-life, so you need to taper it. If it's stopped abruptly, patients will have really uncomfortable withdrawal syndromes. It's not life-threatening, but it is extremely uncomfortable. Headaches, jitteriness, flu-like symptoms. These electric shock-like sensations. So patients will be sitting there and all of a sudden they'll feel like a really painful electric shock on their face or in their body. And this can last for days and weeks. So it really is important to taper your patient's medication on venlafaxine. And desvenlafaxine, very similar to venlafaxine. It's just a metabolite of venlafaxine. So as far as the side effects, very similar. And make sure you taper this slowly as well. Duloxetine, which is Cymbalta. It's similar side effects to the SSRIs. Other special type of antidepressants, mirtazapine, which is Remeron, increases the release of both serotonin and norepinephrine, but also it's a histamine antagonist as well. Give this generally at night because it causes sleepiness, and it also causes a significant amount of weight gain. So you don't want to give this to a patient who's already overweight. It can be useful in patients suffering from cancer or the elderly who are very thin and frail and aren't eating that much, to help stimulate their appetite. Trazodone, which is also called Desiril, it inhibits serotonin uptake, but also it's an antagonist of alpha-1 adrenergic receptors. Most common side effect is also sedation, orthostatic hypotension, and headaches. Priapism, it's rare, but it's serious, so you need to educate your patients on this before starting them on trazodone. And generally we use it not for antidepressant effects these days, just because it causes so much sedation in the dose that it takes to be effective for depression. All of your patients will just end up being sleepy all day long. So we use it in little lower doses as a sleeping aid in 50 milligrams to 100 milligrams at night to help with sleep. The tricyclics are an older class of medications. They're just as effective as the SSRIs, but they have a lot more problematic side effects. They're extremely lethal in overdose, and it only takes a small amount to actually kill someone. 1 week supply will do the job. And treatment in an overdose, in addition to all of the other things that are standard in overdoses, you can use IV sodium bicarbonate. Here's an example of an EKG finding in a patient who has overdosed on a tricyclic. You see it causes widening of the QRS interval. The side effects of tricyclics, the most problematic are generally the anticholinergic, which, especially in the elderly, is a problem because it will cause more constipation, more urinary hesitancy. Sexual dysfunction can occur. The antihistamininergic effects are sedation, carbohydrate cravings, weight gain. Alpha-1 adrenergic receptor blocking causes more of the orthostatic hypotension, and this also more of a problem in the elderly because they are already at risk for falling. The cardiac effects, always avoid tricyclics in any patient with a history of heart block or prolonged QT interval. Tricyclics, remember, they're a class 1 antiarrhythmic, so they do prolong the QT, and you need to get a baseline EKG before you start the medication. And generally, if you're titrating it, you want to get it periodically, and it's safe to get an EKG on a yearly basis just to monitor it if they've been on a tricyclic for a while. Toxicity. In an overdose, you're going to look for anticholinergic toxicity, dilated pupils, blurred vision, dry skin, urinary retention, confusion, seizures, and arrhythmias and coma in severe cases. Always avoid in patients with prostate hypertrophy or patients with glaucoma. And you can monitor these tricyclics with blood levels as well. Here's some examples of tricyclics. You have imipramine, amitriptyline, trimipramine, nortriptyline, desipramine, clomipramine, and doxepin. The ones that are most important for you to know are imipramine, amitriptyline, nortriptyline, and clomipramine. And nortriptyline is known because it's the least likely to cause the orthostatic hypotension. Desipramine is the least sedating and has the least anticholinergic effects. And clomipramine is probably the best for obsessive compulsive disorder because it's the most serotonin specific. Next, we'll talk about MAOIs. The mechanism of action is that it inhibits the degradation of serotonin, dopamine, and norepinephrine, so it just makes these neurotransmitters a lot more available. And they can be useful in the treatment of refractory depression. So in someone who has failed trials of SSRIs and tricyclics, you may try an MAOI. And here's a diagram showing how it works. You can see the monoamine oxidase, which is the enzyme that breaks down these the serotonin neurotransmitter, is in green and in the synaptic cleft. And you can see how the MAOI inhibitor is the pink thing that's blocking the degradation of the serotonin. MAOIs have improved efficacy for atypical depression, which is characterized more by the mood reactivity, hypersomnia, hyperphagia, extreme fatigue when depressed, and rejection sensitivity. However, it's rarely used because of the many problematic side effects. So it may be the most effective for atypical, but it's not our first line choice because of all the problems associated with MAOIs. So MAOIs are associated with hypertensive crises. They have to watch their diet specifically. They cannot ingest anything that is tyramine rich, such as wine, beer, aged cheeses, liver, smoked meats. They can't be used with pseudoephedrine, contraindicated. So with hypertensive crisis, you'll see headaches, stroke, pulmonary edema, cardiac arrhythmias. Extremely dangerous, and this is another reason why we hardly ever use the MAOIs. Other contraindications with MAOIs, you never want to use meperidine, which is Demerol, pain medication, absolutely contraindicated due to the risk of serotonin syndrome. Other things that are contraindicated are the antibiotic linezolid and the migraine medication triptans, as well as the pseudoephedrine. Most common side effect for MAOIs is orthostatic hypotension, but you also see weight gain, sexual dysfunction, and insomnia. The different types of MAOIs are phenelzine, tranylcypromine, isocarboxacid. Selegiline is not a psych drug, it's more of an anti-Parkinson drug, but it is also an MAOI. If you remember these three MAOIs, phenelzine, tranylcypromine, and isocarboxacid, and you remember which ones are SSRIs, then the rest of them are probably tricyclics. It's a process of elimination on the exam if you're having trouble remembering. At least there's only 3 MAOIs, so you can memorize these 3 and remember that they're MAOIs so you don't get tricked on the exam.